Welcome to Talksicology, brought to you by Recovery Unplugged, the place where we talk about all things substance abuse, recovery, and mental health, with guests offering varying perspectives and viewpoints. Hosts Joseph Gordo and Jason Cabello share about their addiction and recovery and other serious subject matter through lighthearted yet candid conversation.
Welcome to the show. We've been here starting the conversation a little bit early about
old man talk.
living into your hundreds.
Yeah, that's right.
So,
and the woes of being 55.
yeah, and the woes of being 50 and the woes of being 30. 40.
30. Jesus, come on. Yeah.
I'll try to show you a good one.
You know what's so the second I turned 40, right? Like the first workout I did afterwards, like my hand got all swollen and someone said, "Oh, you probably injured like your flexor in your wrist and then whatever from holding the bar wrong." And I was like, I held the bar the way I've always held the bar. And they were like, "Yeah, but now you're 40."
Yeah.
But it was like one day to the next.
I get it.
Got to start watching the
my wife and I kind of have this running joke, like when you're a kid, you'd play that game where every time you saw like a Volkswagen Beetle, yeah. So we kind of have a similar game for men who are like obviously 50 plus, but very thickly muscled.
Yes.
And, we have this thing about like he's on steroids or he's on steroids.
Yeah. So we used to do this thing when we would
He's
go to ACL.
obviously on steroids.
Yeah. Well, when we would go to ACL, right? There's all shapes and sizes of people, ages, but there was a demographic that we referred to as cheeseburger girls.
Okay, I like it.
So they were so skinny that you want to go give them a cheeseburger.
Please.
Yeah.
Just
Malnourished.
Yeah.
Hop daddies.
Like cheeseburger girl. Yeah, right there. But welcome to the show, Doc.
Good to be here. Yeah, long time no see, and nice to be
here
with you guys.
Yeah, you're like a low-key celebrity in Austin. You're like a man who's around.
Tell me more.
Your name comes up in conversations. People are always in awe. I feel kind of cool when I refer.
And now
to
you have to sit here in the flesh.
Well, I like it when there's conversations going on about you, and I'm like, I'll talk to Carlos. And
Carlos. First name drop. Good.
No, I was talking to my friend Carlos. You might know him. Carlos Tirado.
Chuck.
Yeah.
It's Chuck.
Chaz.
Chaz is my favorite. Yeah.
But you stay busy. You know what I mean?
Yes.
You're someone that we don't see you very often because you're grinding.
I joke that I'm the hardest working Mexican in medicine.
Yeah.
Definitely.
I like that. And oddly enough, there are a lot of Mexican doctors in Austin, especially psychiatrists.
Yeah.
Someone asked me recently, like, "Hey, who are some psychiatrists you recommend?" I was like, Dr. Robert Cantu, Dr. Carlos Tirado, Dr. Isela Wershin.
Yeah. That's right.
And I was like,
representing.
I was like, am I showing my bias or is this just
no? The raza's strong.
Yes,
here, for sure.
They're trying to fix that generational trauma.
That's true.
Yeah.
But so you are a doctor.
Yep.
Like a real doctor, not a online doctorate in divinity kind of doc.
Jazz.
and you are the founder, co-founder and CEO of CARMAhealth.
That's right.
Which is a addiction and mental health focused medical whole person I totally said that wrong, didn't I?
Yeah. We founded CARMAhealth in 2017, so we just had our 7th anniversary, and that's how we were set up. We were set up as a medical group with doctors, nurse practitioners, and we do combination of primary care and psychiatry, behavioral health. And CARM is actually an acronym. It stands for Collaborative Addiction Recovery Management and Assistance.
How did I never know that?
It's on the website.
I just thought y'all spelled it weird.
No. It's a remnant of my time in academia. Like snappy acronyms. You can always kind of think
to keep
of
things in your head.
That's right. That's right. And it's also the first 3 letters of my name.
Oh, self-serving there.
Oh, yeah. I like that. So, I mean, let's rewind a little bit because Jason and I work in recovery because we were drug addicts who got sober, and we're just kind of like, well, what am I doing with my life now, right? But you're part of a smaller, unique class of individuals that is not in recovery, that has found a heart for this work. So, I know you're originally from the Dallas area. But what is the chain of events from like deciding to be a psychiatrist, deciding to be a doctor, to deciding to devote your life to this work?
Yeah, it's been deeply personal on one level, but also very scientific at the same time. I joke that I'm not in recovery, but I really tried to be a person who would be in recovery.
Your best.
Yeah, like if you saw me on paper, when I was a kid, you would not think I'd be sitting here right now, So I was very novelty seeking. I had undiagnosed, untreated attention deficit disorder. I gravitated, toward these very dynamic and interesting people that we may also call sociopaths.
Such lovely language, right? Dynamic and interesting, right?
And I was exposed to substances at a young age. And
so what kind of circles were you gravitating towards when you were younger?
Well, I grew up firmly middle class, but there was kind of, an element, if you will, within my extended family that was very kind of rough and knee deep,
Okay.
And my parents, fortunately, sacrificed tremendously and sent me to private schools, because if I had gone to the middle school and high school that I was, I guess sectioned in or whatever, it would not have been good.
Yeah, especially if that was, the mid to late 80s. Gang activity was the cool thing to do. We didn't have the internet. We would just go and fight each other in an alley somewhere.
Oh yeah. In fact, my brother went to the high school after, because Catholic school goes from like K to 8th grade. So you're kind of a little bit through middle school, then you go into high school. And the first day we went to pick him up from the high school.
Tattoo, face.
No. Face tattoos really weren't in then, right? Yeah. This was probably what, like 1978, probably. The doors to the school burst open, and this, flood of kids come out, and two kids just throw down.
Right there.
Wow.
Oh, man.
So I looked at my mom. I was little. I was like, is this a school I have to go to?
Right.
Is this what it's
like?
Is that
what high school is?
She's like, no, mijo, if you don't want to go, we'll figure it out.
I didn't know we had that in common, that, I was from, my mom was a teacher, put me through Catholic school on a teacher's salary. And I was definitely like, I've talked about it on the show, like I had some stuff from being the poor kid at the private school.
Yeah.
But I didn't know we had that in common.
Yeah. Oh, yeah. So that was great. The investment they made in that kind of education was huge, but I still was very, kind of a risk-taking kid. And there really wasn't a drug that I would not take around that time.
Yeah.
And many nights, going to the clubs. Ecstasy was legal at one point when I was in high school. It was just kind of an open world at that time in Dallas. And a lot of time just hanging out with a bunch of disaffected Gen X punks.
And here
breaking
we are.
into warehouses and just running the streets, really.
That's my favorite characteristic of the Gen X generation, is the disaffectedness. Like that, like Daria.
It was very real.
House, like,
it really was. Like the less you cared, the cooler you were. It's whatever.
Yeah, the earth.
Yeah. So one of the things, even from that time, that I noticed was that I was always able to keep my shit together. And I had a stop button, if you will, in my brain. And I was always curious just from like a behavioral standpoint, why is it that some people lose it, when they've taken substances at that time, like they can't handle it or whatever.
Yeah.
And then why are some people not like that,
So already the academic.
Yes,
Yeah.
very much so.
Yeah.
With your
I was
friend.
observing differences between people. Yeah.
You were Dr. Kevin Hart before it was cool. Right?
So in your friend group, knowing that, you could kind of manage and maybe not do as much as
Yep.
everybody else did,
Yep.
did you kind of have this, like, a little preview into what your career was going to be?
Unknowingly, but yes, absolutely. Because once I really got serious about doing medicine, and I had to work my way into it because I kind of screwed around a little bit early in college and sandbagged myself.
You weren't getting all the scholarships.
Yeah, like doing acid, the day before your biology midterm is probably not a good idea.
I mean, that's how they discovered the DNA helix, like the double
Sure,
helix, right?
But not this guy. I discovered the F grade on the biology. Yeah, no. So there was always that differences kind of thing, and also the fact that it didn't really matter who you were. Like there could be a person who, came from a great family, had great resources, but nevertheless, just became a monster, after they had a few drinks, this kind of stuff, right? So I worked hard to get into medical school and really did not want to do psychiatry. It was the furthest thing from my mind. I actually wanted to be a surgeon.
Any particular specialty that you think?
Vascular surgery, because I had actually been mentored by one in Dallas and worked in his lab for a bit. And, I was Mr., showing up to the ER and wanting to do stuff, like stitch people up or, and they let us back then. We were going to this county hospital in Houston, and they would let us do a lot.
Really?
Hey, you want in on this? This is pretty cool.
Real busy, like, go ahead and finish up here.
Yeah.
You want to run the central line? No, it was crazy. This kind of stuff they let us do. If we were interested,
It's like liability
really motivated.
city.
It was that whole surgeon, well, again, it was a real bro culture, and they're just like, whatever. Sure. It was nuts. So yeah, you can't do that anymore. So that was my focus. But when I did my psychiatry rotations, it really resonated with me. And I just found it incredibly interesting, getting into the stories, that people had to tell, how they kind of got where they are. People who are extremely psychotic, and delusional, just hearing kind of the way the mind can produce like its own reality, fascinated me. And then the fact that, people could really improve, with treatments was pretty cool too. So that got me on the train, to do psychiatry. And I've never looked back. It was one of the best decisions I ever made. I talked about my untreated ADHD. One thing about psychiatry is it's just never boring. It's just always fascinating.
Well, every case is just wholly unique.
Everything's
right?
different. Yeah.
And it all, every aspect of a human impacts the work, right?
Yeah.
Their upbringing, their socioeconomic status, their neurobiology, their life experiences regarding trauma, right?
That's right.
Just all of it.
Yeah. Well, that was what was always kind of drilled into us, this whole idea of biopsychosocial, that was kind of the governing principle on how to understand someone, from a psychiatric perspective. So that was deeply influential. And then the addiction piece, I didn't know that addiction psychiatry was a subspecialty of psychiatry. It's its own thing, right? Just like cardiology is a subspecialty of internal medicine, right?
Well, I mean, psychiatry is a newer medical science, right?
Sure.
And then
that's
addiction within that is a newer medical science, right?
I would say biological psychiatry is the newer part. I think psychiatry, in its earlier stages, was very much wrapped into neurology in a way, and then with kind of like the Freudian revolution, where you started talking about the subconscious therapeutic process, stuff like that.
Everything's a penis.
Psychiatry
right?
Can be.
If you try hard.
Yeah.
If you try hard enough. Yes. There's this other concept called, vagina dentata.
Everything. Oh, yeah.
Have you heard of that? Yeah. So it's pretty, anyway, the thing of nightmares. But so that actually caused psychiatry to take a little bit of a detour into more of that psychotherapeutic paradigm.
Yeah.
That you can actually, resolve conflict. Freud had, very strong theories that still influence us. But then you had a real, kind of expansion of different schools of thought, from Jung to Adler. I mean,
Skinner.
And then Skinner going to the behavioral side, absolutely. So psychiatry kind of has made kind of these full circle, type developments. So when you got into behavioral psychology and psychiatry, the way in which psychotherapy that's more cognitive behaviorally oriented, right? It's more testable, so I think that's one of the reasons why it's kind of had more of an evolution. And then things like psychoanalysis have kind of retreated in a way.
Yeah.
But interestingly, some of those principles are kind of coming back on some level in terms of, this idea of trauma-informed care, processing, of trauma, things like that. Some of that does borrow from analytic processes, like how we address patients, how we handle the space in which they are, stuff like that. So those are very valuable conceptual frameworks, even today.
I remember this story you told me once about when you were first working. I don't know if it was when you were first working in addiction medicine, but I want to say you were working at Shoal Creek. And the detox protocol for alcoholics was still
beer.
Drink 2 beers. Yeah.
Couple beers.
Yeah, a couple beers every couple hours. And it just I always think of you as a very forward thinking, kind of always on the cutting edge of stuff.
Yeah.
And
I immediately switched it to vodka.
Yeah.
That was my
nice.
Yeah, absolutely.
The good doctor.
Cleaner.
Yeah. Cleaner, better on the kidneys, right? But I mean, that wasn't that long ago that was in fact like a prescription for detox.
Yeah.
Right?
more specifically, that was at Brackenridge Hospital. Yeah. And that was a thing. It was a thing to just give people alcohol, in the hospital. And it wasn't just a Brackenridge thing. That's been, had been kind of a old school, kind of approach. Not incorrect when you think about it, right? But
it was like a taper.
Certainly not what we'd call like a standardized medical protocol. And not very testable, in some ways. So being able to bring in best practice, kind of updating things, certainly,
you helped develop a new protocol.
Sure.
Right?
Oh, absolutely. Yeah. We did a lot actually to try to early identify people at risk for withdrawal. A little known reality is that complications of alcohol withdrawal in the hospitals are huge drivers of bad outcomes and high costs in hospitals.
Really?
At the time we were reviewing all this stuff, the hospital can churn out a report of like, who are the 10 most expensive patients we had in the hospital last year? Which ones cost like hundreds of thousands, and I believe like 4 out of the top 10 were drinkers who had complications of their chronic disease in the hospital.
And they were like, we got to do something
along
about
with
that.
withdrawal. So early identification and treatment, huge. You can save yourself a lot of problems if you can just identify them, start treating them before they start getting really sick.
In my
Once they get
experience-
really sick, it's kind of the horses out of the barn for alcoholics. Yeah.
Well, in my experience, stopping drinking and doing drugs definitely has saved me a lot of problems.
Yeah. Oh yeah. Yeah.
So, some of the other projects that I know that you've been involved with that have stayed on like kind of the cutting edge, was the Sparrow, I think it was called at one point, the neurological detox opiates device.
Yep. It's a wearable device on your ear.
Yeah.
That's right.
Yeah.
So what is that?
The technical jargon is transauricular neurostimulation. And that actually, it's a wearable device that will provide specific frequency stimulation at one of the extended branches of the vagus nerve, which is cranial nerve 10. And if you know anything about the vagus nerve, it's involved in a lot of kind of homeostasis regulation. There's even some implication that it has, mood effects, gastrointestinal effects. And the stimulation can actually help reduce the severity of alcohol withdrawal. So we did the study. It was actually the first human trial, control trial.
The one we did at Recovery Unplugged?
Yeah, during COVID.
Yeah.
And we actually showed quite an impressive decrease in opioid withdrawal scores, especially within the first hour. And then it carried forward over 5 days in terms of helping blunt withdrawal symptoms. Yeah. And these were people who were coming just off heroin. There wasn't much fentanyl going on at that time.
Not the on-purpose fentanyl.
Right. Yeah. With no, other than just regular basic medication support, right? So we weren't incorporating Suboxone, which helps keep people much more comfortable. So that was a big deal. You were able to
it was in place of Suboxone.
Yeah. So we did not use the Suboxone assisted protocol. We just did the device plus like the clonidine and the
regular
Zofran, all that stuff that you take, right?
Yeah.
So it was impressive. It was good enough, to get them FDA clearance. Yeah. And since then they've developed a more kind of refined device. Yeah. Really nice design, because at that time we were using kind of like
it was clunky,
this clunker, and so they've done a great job. Yeah, the company's called Spark Biomedical. It's based out of Dallas. Yeah, and they've been great. I mean, they've really expanded the use. We're actually involved in a couple other studies to help kind of open its indication for continuous use.
I think depression, right? There's
some stuff in depression and trauma as well. We did show some appreciable decreases in depression and trauma scores as well during that trial. So we're trying to kind of follow up on that. And then the idea of being able to use it ongoing if you have like post-acute withdrawal symptoms. Mm-hmm. That's kind of like the next level, having people
because like helping with the detox is just the first little piece of somebody actually getting it
right. And if a person doesn't convert to like maintenance treatment, for example, they can still feel really raw and pretty bad for weeks, sometimes months.
Absolutely.
So incorporating the device for those types would be, helpful as an ongoing thing,
But so that device is one example of you staying on the cutting edge. I mean, you were the founding medical director at Recovery Unplugged Texas, right? I think you joined. I think you were like consulting before I even joined the team.
That's right.
And even now, right? Like our medical director, did her residency
she was the first doc I hired.
Yeah. So like, your fingerprints are everywhere, right?
Yeah, it's been nice.
But I think like, the real cutting edge, and I think the thing we want to talk about today is, I think psychedelics, specifically ketamine. Last year I had the opportunity to go to that MAPS conference in Denver with Dr. Wershen. And I always talk about it because it was the most fascinating conference I'd ever been to, because there was these three distinct groups of people there.
Yeah.
There was was the people who wanted to talk about like medicine. You know, those kind of guys, like growing mushrooms in their backyard.
Right.
Then there was the actual professionals like myself and Dr. Worshin, who were, licensed people.
Right, yeah,
wanting to see some research and some data.
Sure.
And then there was the VC guys, talking about billions with a B.
Hello.
All over the place.
I know, yeah.
But, that conference really excited me. And I know that I believe that what I see is like the future of a lot of mental health care is heading towards the acceptance and adoption of psychedelics.
Absolutely.
Right?
Yeah.
Here in Texas, most of them are not legal.
Right.
But ketamine is a notable exception.
Yep. That's right. Yeah. Ketamine has been a commonly used medication since 1970. It's primarily indicated for analgesia and pain control. And it was actually developed as an alternative to phencyclidine, also known as PCP.
Oh
wow.
Yeah.
Wait, PCP had a purpose?
Oh, yeah. PCP had been used as an analgesic for surgery.
Really?
And it had been used in veterinary medicine. It's still used in veterinary medicine.
Really?
Absolutely. PCP is one of those, drugs that it has just like the weirdest, worst reputation, angel dust and all that stuff.
I've never been a fan.
Gonna smoke a cigarette and then take your clothes off and jump through a fence.
You become superhuman, all that stuff. But it has been used and is used in medical applications. But it definitely had problematic side effects. It could cause, just some cardiac instability. Yeah. It was longer acting, so a little more difficult to recover from its effects. So ketamine was developed as an alternative, kind of a cleaner version, and to that degree, it was excellent. Short acting, very safe, not as much risk for cardiovascular complications, didn't depress your breathing, right? Yeah. So you could use it in combination with an opioid analgesic. In fact, it's well known that people can use less opioid post-surgically if they have ketamine. Yep, absolutely. So ketamine's been used like that forever. And I'd say it was around 2000-ish that its use for psychiatric applications became realized, okay? And ketamine is a Schedule 3 drug, okay? So it's not a Schedule 2, which has kind of a higher level of control. And so in that application, it was found to, at lower doses, help people, with mood problems. Also, people who had things like unresolved trauma, and very much in kind of an underground way. It had been used. It's been used for 20 years. Yeah. Okay. Yeah.
All right. So, at Recovery Unplugged, our mental health facility in Fort Lauderdale, Florida, we're going to start using ketamine treatment.
Yep.
Who do you think would most benefit for ketamine treatment?
Yeah. So the current FDA approval for a version of ketamine called S-ketamine, it's also known as Spravato. That's approved for use. It's intranasal, okay? And that's approved for use for treatment-resistant depression. Okay, so that's out on the market. It's being used quite commonly. And as far as off-label ketamine use, which is one of the most common ways it's done in the medical profession these days, it's used again for depression. It can also be used for PTSD and trauma resolution. And there's a growing literature and interest in its use for substance use disorders as well. There's one study that came out a couple of years ago. I think it was called the RISE study. Utilized intramuscular ketamine for the treatment of alcohol use disorder in conjunction with like a cognitive therapy. Showed some benefit. There's trials in cocaine, for example. I don't know if there are any active trials in opioid use disorder, but there's no question that ketamine can help reduce opioid withdrawal, discomfort, and when used appropriately, can actually be beneficial. To help people kick. So yeah, there's a very promising application for it. I think like one thing that we're seeing is the intranasal is good. It's effective. It's only available in 2 doses, and it can have a variable absorption. Okay, you just think about your nasal membrane. Like
if you've got
cedar fever, and you put it up your nose, you might not absorb. Stuff like that is a little bit of a complicating factor. So a lot of folks are just going more toward intramuscular or infusions, so like intravenous infusions.
Question. So would you unpack the term treatment-resistant depression for us? Because, I think we hear that a lot in relation to the ketamine conversation. But, when can we officially classify depression as treatment-resistant?
Treatment-resistant depression is actually, it doesn't take a lot to be considered treatment-resistant. Essentially, it's 2 to 3 full medication trials. So not just trying it for a week, but really true blue full medication trials at appropriate doses, and having attempted some form of therapy, psychotherapy. So if you have persistent recurrent depression in that context, you're considered treatment resistant.
So somebody who they've been struggling with depression for 5 years, they saw a therapist for a year, they've been on 3 different meds.
That's right.
They're someone who, ketamine could be the thing for you.
Certainly for absolutely. Either the Spravato kind of, that you can, sometimes get paid through your insurance, or just, kind of an intramuscular infusion. Absolutely. That would be someone that would be a good candidate. Persons who have struggled with medications, just haven't had adequate responses. Those are typically the people that we'll see who express interest in doing ketamine for depression.
So is this something that's like prescribed? Like you would give someone ketamine? Do they get like take home and can take it on their own? Because I know for someone like me, I'm going to take as much as I can of everything.
Yeah.
Like,
I'm
1 to 2 doses? Yeah. 2 to 3.
Yeah. I'm not a big fan of unsupervised take home. In fact, there's zero literature demonstrating benefit of it would be called compounded, because in order for it to absorb properly, it has to be absorbed sublingually. You can also absorb it as a suppository.
Oh,
yeah,
nice.
Yeah.
You take a bunch
so
of those.
It's got absorption issues, right? So it has to be compounded, and they're dispensed as either suppositories or what they call troches,
like little lozenge.
So dosing of that's kind of variable. It's done under a compounding pharmacy standard.
So someone's by hand making these.
That's right.
Yeah.
So again, there's no real evidence base for that. And sometimes especially for people who are new to this, you can have some pretty disturbing experiences on it that you don't have context for. And if you're not appropriately supported, it can be a very negative experience for people, right? So I'm just really not a fan of the unsupervised self-administration. And then, like what you're saying, right? If a person has a risk or propensity for overuse, that's a problem. It can get dangerous for a person to take too much of it at one time.
And that's something that I think, from when I went to that conference last year has been like a lingering concern of mine. Is there's a lot of really good evidence for a lot of these psychedelics, including ketamine.
Right.
But it doesn't seem like there's a real wealth of data on those things for someone who is in recovery from a substance use disorder, right? Because the old kind of recovery wisdom is, you take a little bit, it's going to trigger that phenomenon of craving, and it's off to the races, right? So, like, do you feel like there are some risks for individuals who are in remission from a substance use disorder?
Yeah, and the way I would frame it is the kind of the way we think about medication risk. Like there's what we call like a caution or an absolute contraindication or a relative contraindication, right? So an absolute contraindication means like under no circumstance should a person use the medication, right? Like one example would be, there's a medication for acne, for example, that is absolutely contraindicated in pregnant women, right? Or if you're not on contraception as a woman, you're contraindicated to take it because there's a real chance that you could have a birth defect, right? And then you have cautions and warnings, right? So people with these certain conditions could use it, but it has to be very well thought through.
Maybe keep a real good eye on it.
And that's kind of how I would frame it for people with a history of addiction, right? It's where are they at, in their recovery? What was their primary substance of abuse, right? Do they have very strong psychiatric comorbidity that's kind of outside the scope of what ketamine could treat, right? So those are the types of things that you would want to you would want to screen for, right? And one of my critiques, of kind of the open door policy and taking it home is that I guarantee you that level of screening is not going on in a lot of these cases, right? And it's frankly, it's similar to how we got into so much trouble with the pain epidemic, right? These practices were truly not like getting down into these people's histories to determine what their true risk was to have long-term chronic opioid analgesia, right?
I was part of the whole like pill mill culture in South Florida, and this was the doctor shopping days when they didn't have the database when you could just go from doctor to doctor. And I had this one of 5 doctors. I would just go in. And I mean, this guy was just always like nodding out and could barely keep his eyes open. And he would give me extra take home for hurricane supply. Like every time I went in, because I would get this guy into the clubs in Miami, and he'd just be like, "So Jason, how's that ankle doing? Let me see your range of motion. Oh, that's not looking good." And then just
it's purely transactional. That's the issue, right? And these are those are medications that without appropriate, risk assessment, right, people get in trouble with, and I think there's a similar relationship like that with ketamine. I don't think we're ever going to see a ketamine epidemic, because it's simply not as high risk of a drug.
It's not as fun.
Well, sure, right, right. Everything kind of has its thing, right?
Yeah,
and but. If you're really trying to achieve like full remission of a depression, or you're really trying to help somebody with trauma, right? Incorporating the medication with a structured support, an ability to do post-session integration, for example, psychotherapy targeting their problems, it's very helpful, There are different schools of thought, about what's the importance of having psychotherapy along with the ketamine, right? And that also applies to psychedelics as well. Versus is it just the medication, right? And I'm much more on the side of the integration with therapy. And when we talk about, the proposed mechanism of action of ketamine, like why does it work, right? Biologically, it's what's called an NMDA receptor antagonist, right? And NMDA is the primary excitatory neurotransmitter in the central nervous system, so it's super broad in its effects. So we know that ketamine does that, right? But we also know that there are other drugs that block NMDA that don't have any psychiatric, effects, right?
Yeah.
So there's obviously something downstream happening, right? And what's being shown, right, and this is common to ketamine and psychedelics, is that they create more connectivity in neuronal networks. Okay, so we call that synaptogenesis, and that's kind of tied into that whole big think concept around neuroplasticity.
Yeah.
Okay, so ketamine, psychedelics are believed to have effectiveness because of that neuroplasticity.
They help enable the neuroplasticity.
Right. So they don't create new neurons, right? But they create more connections with the neurons, right? And what we see in people who are depressed or people who have, say, PTSD, is they kind of have like a shriveling up of the connections in parts of the brain that modulate your mood or memory, right? So if you think about depression, it's essentially a condition by which your mood, your affective range narrows very tremendously, right? You're just kind of stuck, in this depressive, state.
I think of the term entrenchment. Like your brain has become entrenched.
Some people call it that, or you're like hibernating, you're in a cave, this kind of thing, right? Weighed down. And then if you think about PTSD, it's very much a disorder that has to do with overwhelming stress reaction and memory, right? So there's evidence that ketamine and psychedelics can help kind of revive and spawn more connectivity in those brain regions that help modulate both those processes, right? So we kind of have a general big picture understanding, right? It's like if I throw fertilizer on my lawn, right? I know it can green up. I don't know the exactly,
it's the nitrogen.
Every chain, every length of chain, but it's certainly tied up in that capacity of forming new neuronal connections. And so the other point there, so you think about neuroplasticity. Neuroplasticity essentially is the ability of the brain to form new synapses, new connections, right? In response to learning, experience, or injury, right? So we used to think that the brain was kind of static, right? But we realize that's totally not true, right? Anytime you learn something, anytime you have an experience that impacts you emotionally, or if you have an injury, right, there's a lot of new connections forming and old connections disconnect. There's a lot going on. Even an injury, whole different regions of the brain can be recruited to perform prior functions, So, I mean, there's a limit to it, obviously, but that's the whole idea undergirding.
That's kind of, because I'm not an expert on this, right? But sometimes people ask me, like, what do you think about psychedelics? And kind of like my very basic understanding is, these drugs help to enable neuroplasticity, which is, a key function in being able to change, long-term entrenched ideas, beliefs, coping mechanisms, et cetera, et cetera.
That's right. And that's why I am a proponent of the psychotherapy piece, because what are you doing in psychotherapy, right? You're learning and experiencing. If you don't have a proper container, right, to be able to direct that experience and the learning, it could just not amount to anything, right? You don't have a frame, you don't have a context, you're not able to apply. So that's one of the reasons I do believe that the therapy part is important, right? Especially for people who are uninitiated to the treatments or dealing with certain things that are fairly complex, right? There are people, for example, chronic depressed folks who have had ketamine treatment who've responded well to it, who it's almost like riding the bike, right? They don't necessarily need that level of support because they've taken the medication, they've had a period of therapy, they've gone into remission for their depression, and then can come back, every 6 months or something.
Kind of for maintenance.
Get it. Yeah. Those folks may not need like a full-on, psychotherapy trial, because they kind of understand the terrain.
They've already done some work.
And they're really kind of doing things to really kind of get them out of a depressive phase very definitively.
Yeah. So question, because, sometimes, I think, what happens in therapy and different, with things like EMDR and all these different kind of modalities can kind of be a little nebulous to the to the layperson, right?
Sure.
Let's say I do have treatment-resistant depression. I have no contraindications. I'm someone who's appropriate for ketamine therapy, right?
Yeah.
I come to Karma or I come to you, what does the real process look like, once it's been decided, yes, this person's going to do ketamine therapy, like what happens?
So we do basic screening to ensure that, there's no contraindication to the treatment. There aren't very many absolute contraindications. And when we think about an absolute contraindication, it's something that we think would cause, real medical harm to the person. So certain conditions that increase the pressure in your brain, right? We would not utilize ketamine for. People who have severe urinary or kidney disease, we would not use ketamine. People with advanced cirrhosis, for example, we probably wouldn't do ketamine treatment.
Well, let's say like I've passed all that.
Yeah. The other thing I will add, people who have psychotic disorders, we typically would not use ketamine for. I think that's important to mention. So once you're screened and determined to be not at high risk, essentially you get scheduled to come into the clinic. Most clinics have a very comfortable kind of layout with either a couch or a very plush recliner,
Something
very
cozy.
low light, very kind of retreat, kind of feel. And at that point, you go over the protocol with the patient, how much you're going to get. It's based on your weight. If we're doing intramuscular infusions.
And would this be what's considered a macro dose?
No, it would not be considered a macro dose. We don't really think about ketamine in that context. It's more attuned to a person's weight and what we call milligrams per kilogram. Okay. Lower dose ketamine, so lower milligrams per kilogram, is more of the psychoactive effect. And then if you get higher, that gets more into the analgesia side, right? So there's pretty good consensus that anywhere from 0.25 milligrams per kilogram up to 1.5 milligrams per kilogram is considered that range of psychotherapeutic doses. Getting over that can start putting you more in that kind of anesthesia range, right?
Yeah.
Where you can tolerate it, but you're probably not going to remember anything.
Yeah.
And you're going to, you're just going to be kind of out, So we try to avoid that, obviously. We really want people to have an experience, right, in the context of the treatment in that controlled supportive environment. Now, when a person's in session, right, unlike, say, MDMA, in which the patients are actively relating and processing, right, the ketamine patient is really internal. We'll typically put an eye mask on with music, right? And that's a very internal experience, right? The expectation is not that you're going to be doing active processing during that active medication.
You're going to kind of strap in for the ride, and then we're going to talk about it after.
That's right.
Okay.
That's right.
When the experience is complete after what 2 to 4 hours, I think? Or
no, actually, ketamine is very short acting. From start to finish, most people are lucid within about 40 minutes to an hour.
Okay.
Yeah, so it's pretty rapid.
So the 40 minutes to an hour have passed. Does a person go immediately into therapy before they leave the clinic, or is that something
what
that comes
we'll
later?
typically do is have like kind of a debrief with the patient just to get initial impressions, right?
Like a short, quick.
Yeah. make sure they're okay, right? And then, obviously communicating with their therapist for post-session integration within anywhere from 24 to 72 hours after the session itself.
And so, that term integration, what does that mean?
It means taking what you experienced in the session and integrating it into your treatment goals, right? I mean, that's pretty much the best way to put it. What did you get or learn or experience, and how can that be incorporated in your treatment session? Like, I can give you an example. One patient I treated had lots of trauma in childhood. Was working with a really good therapist in the community, so we're kind of co-treating. And during her session, she was gesturing very much like she was choking. And I knew she wasn't having any true respiratory problem because her oxygen saturation was reading like 99% the whole time. But clearly, she was just gesturing as if she was choking. And when she came out of it, I just reflected back to her that during a certain point of the session, she was and she had actually uncovered a near drowning that she had when she was a child.
Yeah.
In that moment, right?
Okay.
And it had huge implications to her because her mother was a swim instructor and actually had swim lessons at the home. And she wandered into the pool, and her mom was too busy and too preoccupied with whatever she was doing to realize it.
Yeah.
Right. So it created this real rift of mistrust between her and her mom, even from an early age. So that was something she was able to connect with and process in therapy.
Okay.
You know?
Okay. All right. Thank you.
Yeah.
Thank you for that example. Because I think integration is another one of those words, right? We hear it, but like
she made a
in a
very
sense,
fundamental
like?
connection.
Yeah.
Another example, and this is a person who was not in psychotherapy, but was, I think, just psychologically minded enough to be able to kind of do a lot of processing. So this was a gentleman who was, I think, in his early 60s at that point. He had grown up in a high control religion that, had, horrible, stigma against homosexuality. And he knew from an early age that he was gay.
Yeah.
And never came out to his family, okay? But completely distanced himself from them, basically for, 40 years, totally estranged, led a whole life, independent of them, with hardly any contact. And he suspected that some of them knew the reason why, but because of their religious prescriptions, never addressed it.
Don't ask,
right?
don't tell.
It all just,
right.
So he had also had a lot of chronic pain issues in addition to his depression, and he agreed to do a trial of ketamine. And in the process of, he did 6 sessions, he got to a place where he decided that he was going to come out to his family in his 60s.
Wow.
And did so, and found that a very significant portion of his family embraced and accepted him. Amazing. He's totally transformed this guy's life. He felt connected, to some of the most important people in his life, and found acceptance, and they were able to really resolve a lot, So it helped him push through that. And this was another interesting, about a year later, he just emails me and says, I want to come in for one more. Okay. He had a very specific, and he didn't say what it was. So he came in, did a session, and came out, within the hour and felt that he had finally overcome his, that combination of resentment and guilt over loss towards his father, right? Because his father had died, so he was never really able to reconcile.
Yeah.
So he felt that he was able to resolve that.
He healed his father wound.
Yeah.
So, what?
Kind of like he had this kind of mission accomplished, kind of feel that,
Very liberating.
It was very, very important for him, to do that.
So, we're getting closer towards kind of the end of our time. What are some things that you think are important for the general public or, kind of mental health professionals in general to like understand about ketamine therapy in particular?
Yeah. I think, well, part of my interest in this came from just seeing how there are a lot of people out there who've kind of gassed out on conventional medication treatments who are still suffering, okay? And ketamine and psychedelics, which, we can probably do a whole nother show on that, are new tools, that can be distributed hopefully widely for people who have these problems and do hold promise for some of real relief, real relief for these symptoms. I'm not in the camp that over glamorizes these treatments.
It's not a miracle.
They're a tool, and they can be another way, for people who've had long-term suffering from these conditions to actually get relief. Okay. I don't think that, ketamine or psychedelics are necessarily going to come wholesale replace conventional psychotherapeutics or psychopharmacology, but they certainly are going to make an impact. Right. And then, from a practical standpoint, things like ketamine, because of their ease of use and their safety, are pretty easy treatments. I hate to say it, to do for patients in the office. Okay. The interesting challenge for the field is, you have MDMA, for example, you have psilocybin. Those are the biggies, that are being tested. How do we set up our practices to be able to accommodate those treatments, right? Because MDMA is 6 to 8 hours, and psilocybin similar, right?
And I think best practice is like two therapists in the room.
Yeah.
So
how practically, right, do you do that in the context of, helping people, with PTSD in the case of MDMA, or depression or trauma in the case of psilocybin. So those are going to be the real practical considerations that we have to think through about how we apply these therapies. Are there possibilities for groups? It's long been, like ayahuasca, is a group, type of format. So there's a lot of innovation, kind of clinical innovation that needs to be done around all that.
Awesome.
Yeah.
Awesome. Thank you.
Yeah.
You good?
Yep.
Okay, Jason's good. All right, I guess that means it's time.
Jason's good. Everything's good.
Yeah, it's time.
It is.
It's rapid fire question time.
It's rapid fire question time.
Okay, rapids.
All right, classic question here, right? Okay, Ben and Jerry's comes to you and they say, hey, we want to do a Carlos Tirado signature Ben and Jerry's flavor. What do you put in the ice cream and what do you call it?
Carlos's cool and creamy coconut surprise.
Karma coconut surprise.
Yeah.
All right.
What would be the constituent compounds in that? Coconut, obviously. I love pecans.
Yes.
But pecans don't do great in ice cream. So I'd probably go more toward an almond with some kind of caramelishness.
I dig it.
In there.
I like it.
Yeah.
So it's a day like today, a little bit rainy outside. You're driving, feeling a little introspective. What's your go-to rainy day song?
Ooh.
Or rainy day artist? maybe.
Like the artist, yeah.
I think the Smiths. Yeah.
Punctured bicycle.
Yeah. Heaven knows I'm miserable now. You know,
Oh man,
that's a good one.
along that line.
Well, Jason's our resident Smiths guy. I am our resident not Smith.
Yeah.
You know, Smith's
Yeah,
guy?
He's more of a Fallout boy.
Okay.
Okay. Yeah. I just think what's his face is so fucking
Morrissey?
That's why the
I think
Smiths
Morrissey's
were. I
such
know
a
we're
fucking-
rapid
yeah,
here,
yeah.
but the Smiths were before it became just a total like egomaniacal
Yeah.
cult of personality that is Morrissey. It was a little.
Although I saw Morrissey in Liverpool last year.
Really?
Yeah, I went to Liverpool to attend the British Open golf tournament, and he was just so happened to be playing in Liverpool.
We need to
It was
have a
freaking awesome.
we need to have a whole episode on why Hispanics are so drawn to Morrissey.
That is a thing.
It is a thing. I grew up in Miami, and it's not just a Mexican thing. It's a Cuban.
It's
What's that? I saw this thing recently that like the Deftones are Metallica, but just for Mexicans.
Oh,
And I was like, yeah. I mean, yeah. Okay. We had a couple more questions.
Okay.
I'm gonna steal one of Jason's. Time travel vacation. Right. You can go to any period of time.
Oh, wow.
And do whatever you want for where do you go and why?
Well, part of me would want to go really to kind of like ancient Mesoamerica, right? But I'd kind of be afraid of like getting my heart pulled out of my chest.
Yeah.
You know?
Yeah.
It's a very real
Valid concern.
possibility.
And really just disease in general, right?
Well, yeah. Well, before the Spaniards came, it's probably okay.
Yeah.
But I think just from the intellectual and spiritual vibe, I would want to go to like pre-Socratic Greece in like modern day Turkey and hang out with this guy called Anaximander.
Oh, dang.
Yeah.
I'm gonna
Look it up.
I'm gonna have to go Google that one.
All right. Last but not least.
All right. What's the secret?
A secret?
The secret. Seem to be a pretty together guy.
Jason thinks you're wise.
The secret?
The secret.
Integrity.
There you go. Short and sweet and
easy.
rapid. Yeah.
Integrity.
All right. The last thing we like to do before wrapping everything up is just give you a couple minutes to just, use the platform, let people know where they can find you, anything you want to promote. The floor is yours.
Yeah, well, we have this great practice, CARMAhealth. We do offer really a full spectrum of treatment at this point. We started off very focused toward addiction and recovery work, but found that people who are doing well in the addiction and recovery part can still have depression or bipolar disorder or PTSD. So we need to keep treating it. So we've really expanded to really kind of a general, offering. Also, from the primary care side, we really promote, curing hepatitis C, for example, which we do a lot of. Women's health is a real big priority for us as well. So those are things that we're very focused on.
And you're in Texas and Florida, yeah?
That's right. We have offices here in Austin and in Florida, Broward County. Also, if you want more information on ketamine, you of course can go to our website. But also, there's a publication out there that's pretty well known called the Ketamine Papers. Phil Wolfson is kind of one of the gurus, if you will, of ketamine treatment. He has his own website, and then there's some professional training pathways for people who want to become kind of certified ketamine therapists. The Integrative Psychiatry Institute and the Ketamine Training Center. I've actually reviewed those sites. Dr. Werchen has actually had some contact with one of the centers, and those are pretty solid for professionals who want to receive some level of certification and training.
Awesome. Well, Doc, thank you so much for taking time out of your day to come down.
Yeah, it's been a long
Great to
time.
see you again.
Good to see you in person.
Yeah, thank you for your time and for sharing your knowledge and wisdom and some laughs with us.
Yeah, absolutely.
Thank you to you, our loyal listener, for tuning in. And please don't forget to like, follow, share, review, tell your friends. Play this in the car with your kids.
At the gym.
At the gym, yeah.
Wherever, on an airplane.
Yeah, whatever.
On a rainy day.
On a rainy day.
And as we like to say here on Talksicology, there's 1,000 ways in and 1,000 ways out.
Yeah.
And we hope you find yours.
Thanks, guys.